Good day everyone, I am Justin Mirama from Group 6 Subgroup 3 and today we're going to discuss about tracheostomy and as well as to demonstrate how to insert a tracheal tube. Tracheostomy refers to the creation of a communication between the trachea and the overlying skin which may be done either by open or percutaneous technique. Tracheotomy is the formation of an opening that will spontaneously close once the tracheotomy tube has been decannulated, whereas tracheostomy is the formation of a permanent opening that remains open after the removal of the tube. So these are the indications for tracheostomy: airway obstruction, respiratory support, pulmonary hygiene, elimination of dead space, treatment of obstructive sleep apnea, and prolonged mechanical ventilation. It is also important to take note the relevant anatomy for tracheostomy. These are the laryngeal prominence, jugular notch, cricothyroid membrane, and the cricoid cartilage. These are the instruments to be used: local anesthesia, tracheostomy tube, suction, suture set, surgical set with scalpel and forceps, electrocautery, and retractors. Place the patient in a supine position with neck extended by a pillow or bag placed under the shoulders to deliver the trachea out of the thorax and to give adequate access to the cervical trachea. Palpate the cervical landmark starting from the thyroid cartilage, cricothyroid cartilage, and the sternal notch. 2 finger breadths from the sternal notch mark the site for incision. Sterilize the skin of the anterior neck and chest and drape the neck. For the administration of anesthesia, unless the patient can safely be intubated or the patient can be ventilated with a mask, a tracheostomy should be done under local anesthesia. The skin, soft tissue, and trachea should be infiltrated with local anesthesia with adrenaline before induction. Make a horizontal incision in the marked area through the dermis, and the subcutaneous tissue will be dissected through an electrocautery. Once the fascia has been cleared away, identify the strap muscles and retract them laterally. Expose the trachea by parting away the tissues. Create an inferiorly based flap raised from the anterior wall of the 3rd and 4th tracheal rings. A silk traction suture is passed through this anterior trachea flap and loosely secured to the skin. Assess the size of the trachea and select the largest cuff tracheostomy tube that comfortably fits the tracheal lumen. Thread tapes through the holes in the flanges of the tracheostomy tube and pass them around the neck. Tie them with the neck flexed. There are 3 types of complications for tracheostomy. These are intraprocedural, early, which is less than 7 days, and late, which is more than 7 days. Intraprocedural complications include airway fire, bleeding, pneumothorax or pneumomediastinum. Early complications include infection, tube obstruction, and accidental decannulation. Lastly, for the late complications, tracheal stenosis, tracheoinnominate fistula, tracheoesophageal fistula, and tracheocutaneous fistula.